So today's topic is an introduction to pharmacology in the elderly because the vast majority of people in long-term care setting are elderly patients. So the first thing is that absorption is often slower than usual, which results in what's called a delayed onset. So the drug doesn't start working as quickly as you think it should, but it will eventually start working. So it's not that they're pooping drug out the other end, it's just that it takes longer for it to work. Does that make sense? When it comes to distribution, elderly patients often have more fat. So if there is a fat-soluble drug, they're going to have more of that drug in them, which can lead to a buildup over time. So they're having less fat, they're having less excretion because they've got more drug being held in the fat mass. So we typically want to decrease the dose of fat-soluble drugs. They also typically have decreased muscle mass and decreased water, which means that water-soluble drugs are going to be a higher concentration, meaning that those are going to work more than usual. Patients also have decreased albumin, which can actually increase free drug levels. So drugs that are holding hands with albumin are not available to act in the body. The only drug that's available to act in the body is ones that are free, that are not holding hands. So if the patient has less albumin, there's going to be more of that free drug at the same dose. And actually, sorry, I misspoke here. With this increased fat, what could actually happen is it becomes less effective at first because more of that drug has to go into the fat and there's less available to be used. When it comes to metabolism, generally speaking, metabolism is going to be slower, but it's highly variable. So there's no expect this in an elderly patient as far as metabolism goes. Then with excretion, we're going to have decreased renal clearance, and we've got to check creatinine clearance, not serum creatinine. Now, as far as adverse drug events, adverse drug reactions are 7 times more common in elderly than in the regular population. What's an ADR? Adverse drug reaction. What is an ADE? Adverse drug effect, or sometimes adverse drug event. So they're all relatively interchangeable. So if you hear those different things, there you go. Now, most of the adverse drug reactions in the elderly are related to dose, which goes back to you being aware that they might need a lower dose. And that goes back to understanding the normal dosing range. Look it up? Okay, I can do that. All right, now, the adverse drug reactions are even though they're mostly dose-related, are multifactorial. There's a number of different things that can affect those adverse drug reactions. So the first one is the lowered renal excretion, which we've already talked about. Also, polypharmacy. Old people have tended to accumulate multiple illnesses, and so they tend to be on multiple drugs. On top of that, as they go from one hospital to another, doctors sometimes are a little bit hesitant to discontinue a drug that they didn't start. I guess they must have been put on it for a good reason. Let's just keep them on it. So patients have a tendency to accumulate drugs. A lot of the patients that you're going to see in nursing homes and long-term care facilities are going to be on 12 to 16 medications. Yes. So polypharmacy is generally considered 4 to 6 drugs at the same time. And here you've got a patient who's on quadruple to quintuple, that. Quintuple? So difficult. Next is the severity of the illness. A lot of elderly patients have more severe illnesses. They're on the way out. And so you've got to give higher doses. Another one is drugs with low therapeutic index. So the therapeutic index is the difference between when a drug becomes therapeutic and when a drug becomes toxic. And there are a lot of drugs that are used in the elderly for things like, say, heart failure that have a relatively low therapeutic index. And because of that, there's not a lot of difference between therapeutic and toxic. The next one is inadequate supervision of long-term therapy. Now, this is primarily continuity of care. They're not meaning that someone's not watching them take their medications, although that does happen too. The main thing here is there's no one supervising the overall plan of care because they've got this specialist for this and this specialist for that and that specialist for this, and no one's looking at the overall big picture because the cardiologist is only looking at the cardiology meds. Does that make sense? Okay. And then we have poor adherence. Patients who are elderly are less likely to take their medications. Partly because of forgetfulness, partly because, well, I just don't feel like it. You can kind of think of elderly patients as like children in reverse sometimes. So think of how kids are in that kind of I don't wanna, except that now that they're older and bigger and have a lot more experience. So they know how to resist better. There's something called the Beer List or the Beer's Criteria that's published by the American Geriatric Society. And that is a list of potentially dangerous drugs in elderly. What's the key word there? Potentially. So sometimes these drugs are important and appropriate for elderly patients, but sometimes they might not be. So what do we have to do? Pay attention. Pay attention. Pay attention, right. So you gotta check. Hey, this patient's on this drug that's on this list of potentially dangerous medications. Are they at an appropriate dose? Do they have a good reason to be on it? Is there a reason why we could stop it? Was this drug started 4 years ago and they no longer have that problem? You'll never know the answers to those questions unless you ask them. Yeah. So, some additional resources. While you're in nursing school, you've got access to CoursePoint through Lippincott, the Lippincott Advisor online drug guide. You guys will be using that when you go to clinicals to be looking up the drugs that your patient is on so that you can have an idea of, well, what is my patient on? Why are they on these drugs? How are they being treated? You've also got a textbook. Now, you might not have purchased this textbook yet, but it's a textbook for Patho Pharm 1 and 2. And when you get to the grad program, you can use it for your grad pharmacology course too, because I know you're all going to grad school. So don't sell that book back. It is one of the best books in the program. I know, I chose it. Okay, but seriously, it is a fantastically good textbook. There's also UpToDate, which is one of the resources that you have while you're in the program. Also, a lot of hospitals subscribe to UpToDate. And so here's an article about drug prescribing for older adults that you can read on your own time if you feel like it. And then finally, we have the actual beer criteria. It's not the Gerontological Society, it's the Geriatric Society. I don't know what idiot put that up there, but they need to be fired. So here's the actual publication of the drugs. Updated for 2019, because the 2020 isn't out yet. I don't know if they're going to do it 2020. Anyway, so now we're going to introduce drugs that are common in the long-term care setting. These are representative sample, so there's a lot more drugs out there, and sometimes there's multiple classes of a drug. So we're only giving you one example of that class. So when you look a drug up, if it's like, say, NSAID, non-steroidal anti-inflammatory drug, we're going to give you the example of naproxen. Well, there's a lot of other ones out there. So if you see one of those other ones, guess what? It's going to be pretty similar to the drug you learned. Does that make sense? So part of the reason we're doing this is to give you a little bit of familiarity with a class so that when you encounter another drug in the same class and you look that up and you're like, oh, I've never heard of that drug before. I don't know anything about it. Oh, that's the same class as this other drug I'm supposed to know. Therefore, I know something about it. Does that make sense? Okay. And I just gave you that, just walked you through that with a different drug example there. So the slides provide an overview. They're not a comprehensive treatment of the drugs, so it's not a substitute for a textbook or an online drug guide. All right, so here's a list of drugs we're going to be doing. 22 drugs. Excuse me, Dr. Heyman, you said we were going to learn naproxen, but ibuprofen is on that list, and I feel like you've cheated me. Welcome to nursing school. All right, so some common abbreviations in this PowerPoint that you might see. CAD is coronary artery disease. Myocardial infarction is MI, heart attack. HF, heart failure. CHF is chronic heart failure. Sometimes used to be called congestive heart failure, but that's like old. HTN is high blood pressure or hypertension. SLE is systemic lupus erythematosus, which is an autoimmune disease. PE is pulmonary embolism, where you've got a blood clot that floated up into your lungs. And then DVT is deep vein thrombosis. Have you guys covered that yet? Deep vein thrombosis? Okay, So you have an idea. All right, next we have what are called anticholinergic symptoms. So anticholinergic symptoms are particularly bad in the elderly. So you've got, these are drugs that block your parasympathetic system. So your parasympathetic system normally causes glands to secrete. So tear ducts, saliva, your nose, gastric secretions, helps you go to the bathroom, causes bowel movements, helps sweat to, well actually that's under sympathetic, but same, whatever, makes you sweat. So if you have anticholinergic effects, all those things go away. So a patient will have red skin that is typically dry because they don't have sweat. So if you've ever seen someone who's really hot, what happens to their skin? It turns what color? More red. Why is that? Because your body's going, well, the sweat ain't working. Maybe we should vasodilate, get the blood more to the surface, and then they can just radiate heat off. Does that make sense? So patients who are in this situation are going to have more reddish skin, typically dry because they're not sweating, and everything else is going to be dry as well. They typically will have trouble seeing. We call that blind as a bat because of mydriasis. How many of you guys have ever had your eyes dilated? Okay. So when your eyes are dilated, you have a really hard time focusing up close, right? And everything looks really bright. Well, that's what these patients who have these adverse effects tend to have. And in the elderly who already have vision problems, it's going to make things a lot worse. We can also say mad as a hatter, which because these drugs can cause memory loss and altered cognition, and it can actually mimic Alzheimer's disease.
Could this possibly cause some type of toxic effect since they're not sweating or pain or anything?
Why, yes, it could. So the question was, can this cause a toxic effect? Yes. It can also cause high heart rate, tachycardia, and then constipation. And then I mentioned you have urinary retention up there. So collectively, these effects are known as anticholinergic effects. We'll learn more about them in Pathopharm 1, but there's quite a few drugs that have anticholinergic effects. We're only learning one of them today that has really significant adverse effects like that. But anytime you read about a drug having anticholinergic effects, what do we mean? All this stuff. And in particularly in the elderly, it can mimic Alzheimer's disease. And that's why one of the reasons why we want to avoid drugs that have that. All right, our first drug is going to be aspirin. So aspirin is what's called a non-steroidal anti-inflammatory. It works by inhibiting an enzyme called COX. There's two enzymes called COX, COX-1 and COX-2. So the therapeutic effect of aspirin, 99% of the time that you see it, is going to be to prevent platelet aggregation. Now, what do platelets do? They help with clotting. So why would we want you not to clot as much?
If you're at risk for heart attack?
Well, if you're at risk for clotting in your heart, that could cause a heart attack. So the main reason why we give aspirin is to reduce the risk of heart attacks and then also strokes. You can also give aspirin as a treatment for heart attacks and strokes. So the prevention dose is 81 milligrams most of the time, and the treatment for an active stroke or heart attack is 325 milligrams. So it can also be used as an analgesic and an anti-inflammatory, but in order to get those things to really happen, you've got to give them at higher doses, and the risk of adverse effects goes up. So there's much better NSAIDs on the market to treat inflammation and pain. And it can also be used to treat fever, but again, we don't want to do that, partly because of one of the adverse effects of aspirin, which is if you give it to kids who have viruses, they can potentially get what problem? Starts with an R. Rise syndrome. So Rise syndrome can result in permanent neurological damage and retardation in children. So we never ever want to give aspirin to a child who's got a fever. Well, they shouldn't get aspirin in general. The most common effect of all NSAIDs is bleeding, particularly gastric bleeding from ulcers. The way that these drugs work, they reduce the stomach lining of the mucus lining of the stomach, which puts the patient at risk for ulcers, which in turn can bleed and kill them. Now, NSAIDs can upset a person's stomach. Upset stomach is not the same as an ulcer. You can have an ulcer that hurts, and you can have an ulcer that is asymptomatic. But ulcers are potentially life-threatening. Patients can bleed to death. So, most important adverse effect is bleeding from ulcers. We talked about this in children. Very important not to give it to kids. Some patients can get an overdose of aspirin, leading to something called salicylism. Not that important. And some patients will have a hypersensitivity reaction. One thing I did not put on this slide that you should probably pencil in is it can potentially cause renal damage. Now, at the doses we're giving, that's probably not going to happen. But it is potentially. As far as interactions go, the main thing is other drugs that inhibit clotting. By the way, a lot of herbals, like even garlic, can actually inhibit clotting. So patients who take herbal supplements need to be careful when taking aspirin.
When you give aspirin to prevent heart attacks as a treatment, when they say baby aspirin, how many milligrams is that?
Okay, there is no such thing as baby aspirin anymore. It's now low-dose aspirin, but that's 81 milligrams. Why don't we want to call it baby aspirin?
Because you think it'd be okay for
Because you should never give it to a baby. Why?
because it causes retardation.
Risk of Rye syndrome. All right, so next we have ibuprofen. Ibuprofen is the same class as aspirin, except that, in this case, the main reason we're giving it is for the anti-inflammatory, anti-fever, and pain-reducing effects. It is not very effective at all at reducing bleeding for reasons that we'll go into in Pharm. For all we need to know now is that it works the same as aspirin, but different. And the main reason we're giving it is to reduce inflammation. I hate it when people do this, sorry. Reduce inflammation, pain, and fever. The therapeutic uses, you'll notice, pretty much the same thing. As far as adverse effects, pretty much the same thing as aspirin, except for there's no Rye syndrome.
At what point do you know whenever you should try to reduce a fever versus like trying to let a fever do its thing?
Outside the scope of this course, we'll talk about that in Pharm. Good question, though. Adverse effects, we already talked about that. Interactions, same thing. And then nursing actions, assess pain, educate about adverse effects. You get the idea. All right, so what adverse effect would be most concerning in a patient who's got naproxen, who's taking naproxen on a regular basis? Okay, I'll give you some options. Stomach upset, blood in the stool, vomiting, and rash. Blood in the stool. Why? Because GI bleed, gastric ulcers. Now, health assessment question. What will that blood look like? Dark and tarry. What's the fancy name for it? Melena. So, why would it... Some of you are going, what? What is he talking about? You guys need to go back and look at your GI vocabulary. So bright red blood in the stool would be from lower GI bleeding. Digested blood coming from your stomach is going to be dark and tarry, called melena. All right, for the bonus prize, what's the fancy name for bright red blood? Hematochezia. All right, acetaminophen. Now, acetaminophen works by inhibiting COX, but it only does it in your brain. As a result, it can reduce fever and pain, but it cannot affect inflammation. It also has no effect on your stomach or your kidneys. At least not in the same way that NSAIDs do. It does, however, have one really nasty adverse effect, which is liver toxicity in high doses. So the number one nursing interaction is you don't let the patient take too much. Well, define too much. Well, in adults, they can have no more than 4,000 per 24-hour window. Now, what do we mean by 24-hour window? So if you're considering, should I give them this medication now, what do? Look at the last 24 hours. If this dose you're going to give right now is going to make them go above 4,000 in the last 24 hours, you don't give them the medication. Does that make sense? And then as far as liver patients can generally still take acetaminophen, but it's half. So instead of 4,000, it's 2,000. Now, as far as dosing ranges go, regular strength acetaminophen is 325 milligrams, and extra strength is 500 milligrams. Are they going to have any questions on their test where they have to look back in the last 24 hours to see if they can? All right, we'll save that for MedSurg and Patho Pharm 1. I mean, so sad. You guys don't get to answer the fun questions. All right, next we have oxycodone. Oxycodone is representative of opioids. So there's lots of different opioids that are available, and we're talking about just one particular one. The way that it works is by activating opioid receptors. I didn't know you didn't see that one coming. Now, there are multiple opioid receptors, and they have slightly different effects. So sometimes you can have slightly different effects from opioids. But in general, oh my gosh, do you see how many adverse effects there are? Now, on a lot of drugs with that many adverse effects, you don't need to know them all. But with opioids, you need to know them all. Now, as far as therapeutic effects go, the main therapeutic effects are reduced pain, but they also cause cough suppression. So you could use it as an anti-cough medication. And one of the adverse effects of opioids is constipation. So we actually use some opioids to treat diarrhea. There's only one specific one that's used for that, but it is a possibility. So as far as the adverse effects go, the number one most important one is respiratory depression. What do you mean by respiratory depression? I just don't feel good about breathing. Is that what we mean? So what does depress mean? To press down. So we're going to press down the drive to breathe. So how are you going to measure that? Respiration rate. What's the normal respiration rate for adults? 12 to 20. So if it's less than 12, you are not going to give them the next dose of opioid medication. If their respiratory rate is below 6, you have to intervene in some way. So that could be something like getting the patient up and walking, if they can walk, or it might be administering an antidote. What's the antidote to opioids? Narcan. Naloxone. The next one is drowsiness and mental clouding. Those are really, really important because elderly patients are already at risk for, excuse me. And they can break their hip, they can fall down the stairs and break their neck, they can fall asleep at the wheel, they can get confused, all sorts of bad things can happen. Now, by the way, if you are driving while you're on an opioid like oxycodone, you can actually get a DUI. So it's not just alcohol that causes DUI crashes, it's also opioid medications. So we need to warn patients who are on these drugs about operating heavy machinery, including cars. Euphoria. Now, what does that mean? I feel good. Now, only the US government would define euphoria as an adverse effect, but this is the major reason why people might become addicted to opioids. Now, how many of you have ever taken an opioid medication? You're like, there's an opioid crisis, and I'm not part of that crisis. How many of you took the opioid medication and you really hated the way it made you feel? Okay. Well, that would be the opposite, which is dysphoria. And interesting story. If you don't like the way it makes you feel, your chances of getting addicted to it, taking it a week or two for a surgery, guess what? Pretty much zero. The people who are like, whoa, that's good, they're the ones who are at risk for addiction in a short time period. You know who else is going to most likely become addicted? You're never going to guess this one. Someone who's already an addict. True story. Sedation. Sedation is related to drowsiness and mental clouding. Constipation. One of the things that we've got to be really careful about in the elderly especially is their bowel function. So if a patient is on an opioid medication, you need to be assessing their bowel function and promoting good bowel movements. So repeat after me, 3 main things. Adequate water, adequate movement, adequate fiber. Now, that is not necessarily always going to be enough, so we can also add a laxative into the mix if needed. What's the key word there? If needed. All right, urinary retention. There should be a comma there, but hey. So urinary retention, patient doesn't feel like they have to go to the bathroom. When they do go to the bathroom, it feels like the stream wants to cut off prematurely. That is usually not that big a deal, but in elderly patients who already have urinary retention problems, it can actually lead to UTIs, urinary tract infections. It can actually, in some cases, get so severe that they actually end up in renal failure, but that's a whole nother story. Meiosis is the opposite of mydriasis. What was mydriasis? I don't remember. Anticholinergic effect where your pupils dilate. So therefore, meiosis would be tiny little pinprick pupils. That's going to make it more difficult for them to see, so they need to have a brighter room than usual. Opioid receptors are coupled to histamine receptors, so all opioids have the potential to cause itching. You can help that with an antihistamine, but a lot of antihistamines have anticholinergic effects, and a lot of them also induce drowsiness. So, not always the best choice for an elderly patient. And then nausea. All opioids have the potential to cause nausea. That's going to be dependent on the patient. And then colic. Colic is relatively rare, and it's excruciating abdominal pain caused by spasms of the biliary tree that take the bile from your liver to your gallbladder. Whew, man, that's a lot. Interactions. Well, anything that is another opioid or a central nervous system depressant. So you guys remember Heath Ledger? No? The Joker, Knight's Tale? Okay. So he actually died from 3 different drugs that were all normal doses, all prescribed, but the combination of those 3 central nervous system depressants was enough to stop his breathing. So that goes back to drug interactions. Sometimes you can have normal drug, normal drug, normal drug, but all 3 of them do the same thing, and you have a much larger effect than expected. As far as nursing actions go, well, if you're going to be giving a pain medication, what should you do before you give it? And what should you do after you give it? Okay. Respiratory rate. We talked about that, right? What are your cutoffs? 12, what do we do? Hold the medication. 6, intervene in some way. And what's the antidote? Narcan. Next, we have constipation. We talked about that. Fall precautions. Lighted room because of the meiosis. Encourage the patient to go to the bathroom more often than they feel like. And there you go. Any questions about all that stuff? Opioids are can be particularly troublesome, there we go. And particularly troublesome in elderly patients because they're already at risk for so many of these adverse effects on their own. It just makes them far worse. All right, metoprolol. Metoprolol is a beta blocker. Beta is one of the sympathetic receptors. So, what does the sympathetic system do? Boo! Yeah, that. You can thank me later. So, that high heart rate, pounding, shaky, oh my gosh, that chill just went down my spine, I gotta run away. Okay. All of that is sympathetic response. So, there are several different receptors that are associated with that sympathetic response. And beta 1 happens to live mostly in your heart, where it causes increased heart rate, increased contractility, which some of you are still experiencing, and then it also increases the speed of conduction. So remember your heart has like an EKG rhythm. That EKG rhythm is partly regulated by sympathetic response. The more sympathetic response you have, the faster that rhythm will go. So when we block those beta receptors, we have the opposite of those effects. So we have a slower heart rate. We have less contractility. Why would you want there to be less contractility? Well, what does that take? Energy, which requires, you guys are never going to guess this one. It's not like the most basic reaction in your body. Take a deep breath in. Think about it. Oh, oxygen. Yeah. So, what does this require? Oxygen. What if your heart can't get enough oxygen? So, like during a heart attack. Or what if your heart just isn't quite strong enough to meet the body's demand? So we get more and more sympathetic response, and that makes it worse and worse and actually damages the heart. So the main use of beta blockers nowadays is to reduce the risk of damage to the heart from excessive sympathetic response. You can also use it to treat dysrhythmias. You can also use it to treat tachycardia. You can also use it to treat high blood pressure, although that's much less common now, and performance anxiety. Now, how many of you guys have test anxiety? Yeah. One of the reasons we get test anxiety is you sit down to take the test and you're like, my hand's shaking. That must mean I'm nervous. Oh my gosh, I'm nervous! And it builds on itself. Okay. So one of the things you can do with the beta blocker is you take the beta blocker, you sit down to the test, and you're like, heart rate's not bad. I must not be nervous. Huh, pretty cool. Now, part of the problem with that is that you're limited by your heart rate. So if you've got very low heart rate or very low blood pressure, it might not be a good option for you for performance anxiety. But the original research on these drugs for performance anxiety, test anxiety, was done in medical students. So you guys are nursing students, kind of close. You might want to try it. You might not. Up to you. Now, as far as the adverse effects go, it's pretty much, if you think about the things that this is doing by slowing the heart rate, well, bradycardia. If you don't have as much contractility, you're not going to be able to do as much. So patients might feel fatigued and have some exercise intolerance. They just can't do as much exercise as they used to be able to. Impotence. Well, that's no good. Huh. You got to warn patients about that one. But don't nocebo them. Whatever. Low blood pressure. By lowering contractility and heart rate, the patient's blood pressure will lower. So they might end up in hypotension. It can cause heart failure. So here's a quick little thing. What is heart failure? Is that when your heart stops working? No? What's that called? That's called cardiac arrest. So what does the word arrest mean? Stop. So when the police say stop, you're under arrest, they're saying stop, you're under stop. Okay. So cardiac arrest is, what's another word for cardiac arrest? Dead. Okay. So heart failure is not dead. The heart is still pumping, but it's what? It's not pumping as much blood as it should. And there's a number of reasons for that. But when your body wants your heart to pump more blood, what does it do? Sympathetic response. So the sympathetic response is your body's response to heart failure. And unfortunately, in a normal person like you, if you needed to run away or do something, that would work because your heart would go, oh, I need to pump harder. I need to pump stronger, faster. And it would work. But on a person who's got a damaged heart, all it does is make the damage worse. So we can use beta blockers to treat heart failure, but as the drug makes the heart beat less strong and slower, that can actually cause heart failure. And now your mind is blown. So wait a minute. I use the same drug to treat something that it can cause. Yes. Deal with it. So when you see beta blockers prescribed in the hospital or the long-term care facility, most of the time what's being treated is either heart failure or a prior history of heart attack or a dysrhythmia. If a patient's had a heart attack in the past, chances are good they'll be on a beta blocker. If they've got heart failure, chances are good they're going to be on a beta blocker. And if they've got dysrhythmia, chances are they're going to be on a beta blocker. So if you see a beta blocker, what should you first think? History of heart attacks, heart failure, or dysrhythmia. Maybe all three. Does that make sense? Okay. And then they can also cause what's called an AV block, atrioventricular block. So because sympathetic response speeds up the conductivity of the heart, a beta blocker will slow the conductivity of the heart. If it does it too much, the patient ends up in heart block. All right. As far as interactions go, there's a whole bunch of things it interacts with. The digoxin is another drug used for heart failure. Anything else that lowers blood pressure, it can interact with. And insulin is an important one. How many of you get hangry? So what is hangry?
So hungry.
When you get hungry, you get irritable and shaky and headachy and rah. That hangry is caused by sympathetic response. So as your blood sugar begins to fall, so it's not even low, it just starts to do that. That's when you get that sympathetic response causing the hangry. Well, if you're on a beta blocker, guess what you're suppressing? You're suppressing hangry, which means that you're going to be less likely to notice the early signs of hypoglycemia. So a patient who's got diabetes, who's on insulin, they've got to be more careful about checking their blood sugar. Now, as far as nursing actions go, the number one most important nursing action is to monitor the patient's heart rate. Before you give them their beta blocker, you're going to do an apical pulse. How do we do that? Not the right answer, sorry. All right, so put the stethoscope at the fifth intercostal space, midclavicular line, and listen for a full minute. What do we do during that minute? Count the number of beats. Okay, if the heart rate is less than 50, you will not give them their medication, but you will also call the physician and let them know. Does that make sense? So you don't ever just hold it and then wait for the doctor to come later on. You hold it and then you call them and let them know that you're holding it. There are a lot of nurses who are kind of like from the older generation. And in the 60s, when beta blockers were first invented, they were pretty much used exclusively for blood pressure. So a lot of nurses who came up through the ranks, they typically think beta blocker, that's blood pressure. So if a patient's blood pressure is okay, they're like, I'm not going to give them their beta blocker. They'll feel better because they'll be less fatigued. But the problem is they weren't on it for blood pressure, they were on it for dysrhythmia. And then later in the day, the patient goes into VTAC and then has to be coded or rapid response and sent to the ICU. So we never hold the beta blocker for blood pressure. We hold the beta blocker for heart rate less than 50. What's more important to monitor, heart rate or blood pressure? Heart rate. Okay. And also educate the patient on the medication. If the patient is being given beta blocker for heart failure, you give them a drug that's going to make their heart pump even less blood. How are they going to feel at first? Worse. It's going to take a couple weeks to months before it actually makes them feel better. So you've got to warn them about that so they don't stop taking it thinking this doctor's stupid and doesn't know what they're doing. All right, next we have Lisinopril. So Lisinopril is an ACE inhibitor. So you probably remember from ANP2, and if you don't, well, I'm going to pretend like you do, that there's something called the renin-angiotensin dry non-erase marker. All right, so renin-angiotensin-aldosterone system. What do we start with at the top? Angiotensinogen. Angiotensinogen is going to be converted into what? Right, angiotensin 1. What's the enzyme that does that? Right, the renin. And then angiotensin 1 is going to be converted into, you're never going to guess this one, angiotensin 2. Some of you guys try to outsmart yourselves. And what is it that converts angiotensin 1 to angiotensin 2? Angiotensin converting enzyme, also called ACE. Now, ACE also does something else, which it breaks down bradykinin. Now, angiotensin 2 has, well, several effects, but the two major ones we're going to be concerned with. Number one, it causes vasoconstriction. What's that going to do to blood pressure? It's going to go up. The other thing it does is it causes secretion of aldosterone, which is going to cause what to happen? Retain sodium, thereby retaining more water. What's that going to do to your blood pressure? Go up. Now, the vasoconstriction takes place within a couple hours. The aldosterone takes how long to work? A couple days. Now, bradykinin causes vasodilation. So when you break it down into inactive, what does that cause? That was too fast. You want me to say it again? Okay. Bradykinin causes vasodilation. If you break down bradykinin, what effect do you have? You inhibit vasodilation, making it easier to vasoconstrict. So, ACE, more than anything else, is going to cause what response? Vasoconstriction, which is going to raise blood pressure. So, we give ACE inhibitors to lower blood pressure by inhibiting these two things. Does that make sense? All right. So it's going to cause vasodilation, which in turn is going to lower blood pressure. Aldosterone also causes vascular remodeling, where it causes an increase in smooth muscle cells in the media of the artery, but that's a whole other story. Now, as far as therapeutic uses, the main therapeutic use is hypertension. We're also going to use it for heart failure, and we're also going to use it to prevent kidney complications of patients with diabetes. Diabetes damages your kidneys over a long period of time, and a patient who's on an ACE inhibitor is going to have a longer time before they experience that damage. Does that make sense? So, you'll see diabetic patients on ACE inhibitors even if they have normal blood pressure. What's the purpose? In that case, it's to prevent or reduce the risk of kidney damage. All right, as far as adverse effects go, a drug that lowers blood pressure, you're never going to guess. Low blood pressure. And in particular, first dose hypotension. So first dose hypotension means that the very first time you give it, you're going to have a dramatic drop in blood pressure. And that is more pronounced in elderly folks. And elderly folks are more likely to what? Fall. So you got to be careful with elderly folks, and you give them a smaller dose. Well, everyone should start at a low dose and then increase as needed. So that's known in the business as start low and go slow.
Why would you give a medication that lowers blood pressure to treat heart failure?
What's the body's response to heart failure?
Raises the heart rate.
Sympathetic response. What does sympathetic response do to blood pressure?
Raises it.
Okay, now, when your heart has to pump blood out, if the arteries are all constricted, is it harder, or is it harder if they're all nice and big?
It's harder for big. No, small.
Have you ever breathed through a straw?
Yes.
Is it harder than breathing through a nice big snorkel? Yes. So when you're trying to pump blood, the bigger the artery, the easier it is to pump blood. So by causing vasodilation, you actually make it easier for the heart to pump more efficiently. Glad you asked that question. That was fun. All right. Where were we now? I don't remember. So first dose hypotension can also cause a cough. Where is ACE produced in your body? Oh, it's organs. So what produces angiotensinogen? Liver, right. Renin, you never guess. Kidneys. ACE, Lungs. So where are ACE inhibitors going to have a large amount of effect? Well, where ACE is produced. So ACE is produced in the lung, therefore, if you get a buildup of bradykinin in the lung because it's not being broken down, that is going to cause the cough. It's the most common adverse effect and the most common reason for stopping lisinopril or any ACE inhibitor. Next, we have hyperkalemia. By inhibiting aldosterone, you have a potential to raise potassium. By itself, it's pretty small. But if you're giving other medications that interact with potassium, then you have a much higher chance of having problems. So by itself, usually not a big problem or a big deal, but in combination with other potassium-affecting drugs, it can be a big deal. And then the last one is angioedema, which is an allergic reaction to the drug. If a patient ever experiences that, then they should never take an ACE inhibitor again. As far as interactions go, other blood pressure drugs and other drugs that affect potassium. As far as nursing actions go, assess the blood pressure, be really careful about that first-time dose, and monitor potassium. All right, next we've got furosemide. So it's called a loop diuretic. Why is it called a loop diuretic? So what are the parts of a nephron? You got the something artery, and then you got the other artery. You got the Bowman's capsule with the glomerulus, proximal convoluted tubule, loop of Henle, distal convoluted tubule, collecting duct. Some of you are like, yes, you need to keep that in your head at all times. At all times. So, loop diuretics work in the loop of Henle. They're the strongest diuretics that we have. And the way that they work is by inhibiting the reabsorption of sodium. So if you remember, the way that your kidney works is it filters everything that's in the blood into the filtrate, into the convoluted tubule. And then it starts pulling stuff back into the blood. Well, one of the main things that pulls back into the blood is sodium. Because the amount of sodium left in the filtrate at the end determines how much water is going to get pulled into the final urine product. So if there's more sodium in the filtrate, there'll be more urine being produced.
If most reabsorption happens in the PCT, then why is this one the most effective?
Because we don't have any drugs that work in the PCT. And that might be because we just never invented them, but it might be because they're too dangerous. So, there you go. The way that these drugs work is by inhibiting that absorption of sodium, so there'll be more sodium in the filtrate. So there's more sodium in the final urine, which is going to pull more fluid in through osmosis. So, as a result, what these drugs do is they make the patient pee more. That's going to reduce blood volume. It's also going to lower sodium levels. Chloride follows sodium. And the body's response to all this is to secrete aldosterone. Aldosterone causes secretion of potassium into the urine. So therefore, these drugs will also lower potassium. Now, out of those things, low blood volume, low sodium, low chloride, and low potassium, which are the two most important? I don't know. The answer is potassium and the fluid. So, in terms of adverse effects, hypovolemia, low blood volume, and hypokalemia are your two most important. Now, as a person's blood volume goes down, how's the body going to respond to that? Increasing the heart rate. So, tachycardia is a potential adverse effect. These drugs are what's called sulfa drugs. So, if you remember way back to chemistry, when you learned your functional groups like amine, no. Carboxyl? No. Esters? No. Can't believe you forgot ester. Aldehydes? Well, one of those functional groups was sulfa. So, drugs that have sulfa in them sometimes can cause a potentially fatal allergic reaction called Stevens-Johnson syndrome. So, these are sulfa drugs, and there you go. They can also cause, or this drug can also cause ototoxicity where it damages the ear. Now, in terms of interactions, any other drug that interacts with potassium will interact with Furosemide or Lasix. And then anything that affects blood pressure and any other diuretics, and also other ototoxic drugs. You want to avoid having the patient take multiple drugs that are ototoxic, unless you just don't want them to hear. Might be the plan. Now, as far as nursing considerations go, assess, this is urine output, potassium, sodium, chloride levels, and blood pressure. And instruct the patient to take it early in the morning and afternoon. Why? Because if they take it at night, they're going to go to the bathroom throughout the night. And then also, when you've got a patient dealing with a drug, the diuretic, or heart failure, you want to weigh them daily. And then auscultate their lungs. Why would you want to auscultate their lungs? If there's fluid in the lungs, they'll have crackles. As the patient's lungs dry out, the crackles will go away. All right, I kind of skipped over this one. So in terms of the uses for Lasix, if a patient's got fluid overload, we can use that to reduce their fluid overload. Now, number one cause of fluid overload, what is it? Heart failure. Heart failure. Now, edema is often a sign of fluid overload, so sometimes we'll use it for that, but sometimes we'll just use it for edema that just happens as you get older. Heart failure, high blood pressure, it's very rare you're going to use Lasix for high blood pressure by itself. Most diuretics will stop working as the patient goes into renal failure, but loop diuretics will still work even in early renal failure. All right, let's take a 5-minute break. Welcome back. So let's talk about our next drug, which is Warfarin, also called Coumadin. Warfarin is an anticoagulant, which means that it makes a person clot slower. Now, why would we want a patient to clot slower? Well, if they're clotting too much. So, not all anticoagulants are created equal. There's kinds that work on platelets, and then there's kinds that work on the clotting cascade. So the antiplatelet drugs are typically better for heart attacks and strokes, whereas the ones that work on the clotting cascade are typically better for venous clots. So what's the number one venous clot we're trying to typically avoid? DVTs, deep vein thrombosis. So the way that it works is by inhibiting vitamin K. So remember that vitamin K is vital in the production of several different clotting factors. So it reduces the number of clotting factors available for clotting, which in turn is going to increase the bleeding time. As far as therapeutic uses go, it's prevention of DVT and recurrent MIs and strokes, and then also treatment of hypercoagulable disorders or states, which includes lupus, atrial fibrillation, where the atria of the heart just do this instead of pumping like they should, and then mechanical heart valves. Now, the thing about warfarin is it takes about 3 to 5 days to become therapeutic. So what does that mean in terms of what sort of things you treat it? Would you ever treat an acute DVT with warfarin? No. So if a patient's got a DVT, you can't use warfarin. You've got to use something else. That's something else we're not learning in today's lecture. But you can use this for a patient who's already had a DVT and you're trying to prevent a new one from coming or reduce the risk of it coming. Now, sometimes you'll hear me say the word prevent, and really a better way of saying it is reduce the risk of. Why is saying prevent not necessarily as accurate? Because it could still happen. So sometimes in a little student's brain, when you say the purpose of this is to prevent blah, what they go is, oh, blah can't happen. Well, what we really mean is it's reduced the risk that blah will happen. Does that make sense? Yeah. So it reduces the risk of DVTs, but it doesn't prevent them altogether. As far as adverse effects go, you never saw bleeding coming, did you? So, what are petechiae? Little dots on the skin. What are they a sign of? Subdermal bleeding. And what is FOBT? Fecal occult blood test. So, the patient might not have overt blood in their stool, but they're still bleeding through the GI tract. So you look for fecal occult blood. As far as interactions, I said everything. It's not exactly true, but it interacts with a huge number of things. So almost every drug a patient starts or stops, whether over the counter or not, and also a number of herbals, can potentially interact with warfarin. As far as nursing actions go, we're going to monitor what's called INR, International Normalized Ratio. So, in A&P2, I don't know if you guys learned measurements of bleeding. Did you learn that? No? Well, I'm going to tell you, there's two of them. One is called PTT and the other is called PT, prothrombin time. The way that warfarin works is by making prothrombin time longer. But we don't actually measure prothrombin time directly. What we do is we convert it into a ratio. Now, if you divide something by itself, what do you get? 1. So what's normal clotting time in terms of normalized ratio, INR? 1. So when we give a drug that makes it take longer, what will happen to the INR? It'll go up. So the therapeutic range for INR that you're trying to target is 2 to 3 for most disorders. So how would you know if your patient is overtreated? If the INR is 3 or higher. How would you know if they're undertreated? INR is less than 2. Now, what do you think we would do about an INR of 1.8? Is that too low or too high, or just right? It's too low, so what would we do? Increase the dose. What would we do about an INR of 3.5? That's too high, we would decrease the dose. What would we do with an INR of 2.4? That's perfect, keep it. So it's a really simple concept, but you would have no idea how many nursing students think that is the hardest question in the entire world. They have never heard a question that hard before. So if it's low, what do we do? Increase the dose. If it's high, what do we do? Decrease the dose. Now, there's a little bit of a caveat there, which is once you get above 4 INR, the patient is considered toxic, and you want to consider using an antidote. Once they get above 5, you definitely use an antidote. Does that make sense? Okay. So what are the antidotes to warfarin? There's 2 of them. Vitamin K and fresh frozen plasma. Now, what is plasma made of? No. So blood is made of plasma and then formed elements, which includes red blood cells, white blood cells, platelets. So you take those 3 things out, what you got left is plasma. Okay, serum, sure, plasma, same diff. So what is in plasma? Water is good. Give me more. Proteins, including clotting factors. So when you administer fresh frozen plasma, you're administering clotting factors. Now, which one you use, vitamin K versus fresh frozen plasma, somewhat depends on the setting. If you're in an outpatient facility, they're more likely to use vitamin K. If you're in an inpatient facility, they're more likely to use fresh frozen plasma. So, monitor INR, all of that with 2 little words. Then, assess signs and symptoms of bleeding, and it takes 3 to 5 days for work, so we always never use it for what kind of problem? Acute problems. And then, so only used for long-term, never acute. Next, we have atorvastatin, Lipitor, and all statins, generally speaking. So the way that these work is they inhibit an enzyme called HMG coenzyme A, which that's the abbreviation of the big enzyme name. It's the rate-limiting step in cholesterol production. So as a result, your liver cannot produce cholesterol as fast. Because it can't produce cholesterol that it needs to do stuff, it decides, well, I'm going to take it out of the blood instead. So the liver will produce more LDL receptors, which suck the LDL out of the blood, and then the liver uses them for whatever it needs to use them for. So the net result is that statins cause a decrease in cholesterol, and in particularly LDL cholesterol. Does that make sense? Okay. The main use of statins is to reduce the risk of heart attacks and strokes to some degree. But the main thing is to reduce the risk of heart attacks. As far as adverse effects go, nausea, GI pain, muscle pain can be fairly common. Rhabdomyolysis is a potentially life-threatening adverse effect. It's a sudden breakdown of muscle. What's muscle mainly made of? Protein. And what does not get filtered by kidneys very well? Protein. So if you have all of this protein in the blood suddenly, that can clog up the kidneys, causing acute renal failure. And that's the cause of death in rhabdomyolysis. You know what else is also notorious for causing rhabdo? CrossFit. Yeah, strenuous exercise can also cause rhabdomyolysis. There are some reports of memory loss, although it's extremely uncommon, and it's a little bit controversial as to whether it actually occurs or not because of the statin. Question?
So HDL cholesterol is the one that usually causes like blockage and buildup on your...
Other way around.
Oh, it's the other way around?
Yeah.
Oh, okay.
Yeah, LDL is what causes, well, it doesn't, LDL is what's involved in angiogenesis and creation of atherosclerotic plaques. HDL is sometimes called the good cholesterol, although it's not that simple. But some HDL is cardioprotective, and then some is not. It's Pathopharm. More Pathopharm. All right. As far as interactions go, fibrates, which are another kind of cholesterol-lowering drug that are commonly used for triglycerides mainly, will also increase the risk of rhabdo. So you give them both together, and there's an even higher risk of rhabdomyolysis. Nursing actions, typically you're going to give them at night because that's when most of your cholesterol synthesis occurs. However, atorvastatin and rosuvastatin, Crestor, are both now generic drugs, and they are the strongest statins that we have, and they also have very long half-lives, like three days long. So you don't have to give them at night. But all of the older statins that weren't as strong, those should be given at night. Any questions about statins? All right, next we have albuterol, or albuterol sulfate. It is a beta-2 agonist. So what was beta-1? What do we say beta-1 was? A receptor that's involved with what? Sympathetic response. Well, what do you think beta-2 is?
Parasympathetic?
Still sympathetic. But instead of innervating in your heart, it's going to be helping to innervate your bronchi and liver and some other things. The main reason we care about this is for the bronchi. So when you have beta stimulation of the bronchi, sympathetic stimulation of the bronchi, it's going to cause bronchodilation. It's also going to cause a reduction in mucus. Now, those two things help more airflow to go through. So in the fight or flight idea, when you're fighting or flighting, what might you need more of? More oxygen. So at that moment in time, you're going to have bronchodilation, which allows you to breathe better. So beta-2 agonists, most of them are bronchodilators. And that's the main use for albuterol. So the therapeutic uses are COPD. Have you guys talked about COPD? So chronic obstructive pulmonary disease, asthma, and bronchitis in general. So you can use it actually for like an acute bronchitis as well as the chronic asthma and COPD. Albuterol is relatively short-acting, only lasts about 4 to 6 hours, and it can be used as a rescue inhaler. The problem is the more often you use it as a rescue inhaler, the less well it works. So as you use it over time, your bronchial cells become less sensitive to it. They reduce the number of receptors, and those receptors become just less responsive in general. If you give steroid medications to a patient, that will actually increase the sensitivity of those bronchial cells again. So using the inhaler as a rescue inhaler, the more often you use it as a rescue inhaler, the more highly likely a person is to die of sudden death. As far as interactions go, we mentioned the steroids. Adverse effects, it can cause tachycardia, and it can cause chest pain, it can cause tremor. So basically, sympathetic type reactions. As far as nursing considerations go, we want to assess the pulmonary system before and after we administer it. If a patient's like, hey, I'm short of breath, I need albuterol, you're going to listen to their lungs, take their pulse ox, give them their albuterol, wait a few minutes, check those things again. Does that make sense? Okay. Assess the oral cavity if they're breathing it in, they're breathing it in by mouth. Educate about meter dose inhaler use. This is an MDI, meter dose inhaler. And also nebulizer, which is this device down here that the person is breathing in. If they're taking 2 puffs with their inhaler, you wait a full minute between puffs. All right, so everyone get your little imaginary inhaler, shake it. Now what you're gonna do is you're gonna breathe out. put it in your mouth, and you're going to and at the same time. Now, some of us learned how to take our inhalers by watching Goonies, and we learned wrong. So, watch this. It's keep that breath going in, and then we're gonna wait for at least 5 seconds. We're gonna go for 7. So, again, breathe out. And now you can breathe out. And now you do it again, right? No. What do? Wait for at least 60 seconds. All right, next we have docosate sodium or cholase. So this is a stool softener. It's a laxative, but not a very good one. It mainly works by allowing water to penetrate deeper into the feces, and water is the main thing that makes feces soft. The result is kind of like a gooier stool. As far as therapeutic uses go, the main thing is constipation and prevent straining during defecation. Docosate sodium is extremely common in the elderly. It's also sometimes prescribed for patients who have opioid constipation. It is not very effective for that. So if you see patients on that, you say, look, doctor, can't we do something better for them? And you give them alternative. We'll talk about that in Patho Pharm. So nursing actions, monitor the consistency and frequency of stool. Oh, that was nice and easy. Next, we have Bisacodyl. Brand name is Dulcolax, although there's a lot of other Dulcolax products, so you can't necessarily think that you're getting Bisacodyl if you're just buying Dulcolax. It is a stimulant laxative. It actually causes the small intestine to speed up contraction, which is going to stimulate a bowel movement. Now, it acts very differently when given PO versus PR. If you're giving it PO, typically it takes 8 to 12 hours to work. So what we usually say is you take it at night for a morning surprise. If you take it per rectum, which can be either a suppository or an enema, it's going to work much, much more quickly, usually within about 2 to 4 hours. One thing you have to do is monitor for abdominal pain and diarrhea. You never, ever, ever give a stimulant laxative to a patient who has a bowel obstruction. Say that. Now, the good news is in the long-term care facilities, that's not going to be that common. But when you get to med-surg, especially when you're dealing with surgical patients, the risk of that goes up much, much higher. One thing to note is that a lot of elderly folks are obsessed with their bowels. Like, it's a bad day until they have a bowel movement. And, as they get older, their bowels just don't work as quickly as they used to. So a lot of elderly patients will abuse laxatives, taking them even when they don't necessarily need them. All right, next we have milk of magnesia, magnesium hydroxide. This is an osmotic laxative. It can also be used as an antacid. What it does is it pulls water into the bowel, which hydrates the stool, makes it go much faster. Magnesium is fairly poorly absorbed, so it's really difficult to overdose on it unless the patient's got bad kidney function, in which case enough of it can absorb to make the patient toxic and die. So anytime you give magnesium hydroxide, you need to be monitoring what? Renal function, and how do we do that? In the elderly. Creatinine clearance. All right, next we have pantoprazole or Protonix. This belongs to a class of medications called proton pump inhibitors. Now, what is a proton by itself? Let me rephrase that question. What is a proton with one electron? What element would that be? Hydrogen. Take away the electron, what do you have? You have H+. Acid. So a proton pump inhibitor inhibits the production of acid. Where's the main place that your body produces acid? In the stomach. So by inhibiting the production of acid in the stomach, what we're basically doing is we are decreasing the acid level of the stomach. The reason for that is most likely going to be to treat GERD, which is heartburn, gastroesophageal reflux disease, erosive esophagitis, or stomach ulcers. It can also reduce the risk of ischemic ulcers in acute patients. We'll talk more about that when we get to Patho Pharm 1. And then treatment of H. pylori. H. pylori can cause ulcers. And when we try and treat H. pylori, by lowering the acid level of the stomach, you make it less hospitable to H. pylori. As far as adverse effects go, diarrhea and headache are the main two, but this is also one of the drugs on the Beers criteria, and in the elderly, these drugs have been associated with increased risk of fracture, whether it's foot, hip, or back. C. diff, which is an opportunistic disease, or opportunistic infection we'll talk about later on in Patho-Pharm, community-acquired pneumonia, and vitamin B12 deficiency. So, patients who are elderly should generally be taken off PPIs as soon as possible. A lot of times patients will be put on this for a particular reason and then they're just never taken off. So anytime possible, we want to discontinue this medication in the elderly. There's a number of interactions, blah, blah, blah. It can be given PO or IV. And so in the hospital setting, you'll see it given IV a lot. But in the long-term care facility, most of the time it'll be PO. Next, we have metformin, also known as glucophage. This is a medication used for type 2 diabetes. What is the underlying cause of type 2 diabetes? Insulin resistance. And the way that metformin works is by reducing insulin resistance and by reducing glycogenolysis. Now, what is glycogen? Storage form of glucose in two places. What two places? Muscle and liver. So by inhibiting glycogenolysis in the liver, you reduce the amount of blood sugar being secreted into the bloodstream by the liver. The therapeutic use is lower blood glucose in type 2 diabetes. It does not work at all in type 1 diabetes. As far as adverse effects go, nausea, GI comfort, weight loss because of decreased appetite, and in toxicity, it can actually cause lactic acidosis. So it needs to be used with caution in patients with renal failure, heart failure, and history of lactic acidosis. It used to be that those three things were considered contraindications, which mean you can't give it to them. However, it's such a beneficial medication. Now they say you can still give it to those patients, you just use caution. Now, what does that mean? Be really careful about how I give this to you. Is that what we mean by give it with caution? What do we mean? Monitor the patients more carefully. As far as interactions goes, other hypoglycemic drugs, other drugs that lower blood sugar are potential interactions. By itself, metformin does not cause hypoglycemia. However, when given in combination with other drugs, it may. And then as far as nursing actions, this never needs to change to what? Caution. All right, insulin. Insulin is the only effective treatment for patients with type 1 diabetes. All patients with type 1 diabetes must get insulin. It can also be used in type 2 diabetes. The way that it works is it causes your cells to pull in glucose, primarily liver and muscle cells and fat cells. Sorry, fats do not take in. It makes fat cells take in triglycerides. As far as adverse effects go, hypoglycemia is the number one. And when you give it IV, which you're probably not going to do in the long-term care setting, it'll also cause a reduction in potassium. As far as interaction goes, other hypoglycemic drugs, beta blockers, we mentioned that, and then alcohol. Nursing considerations, monitor glucose levels, give food as appropriate, monitor potassium with IV, and don't interchange the types. So insulin types, there's several different types. These are the main ones. So regular is basically natural insulin. It's not used as commonly now, but it's the only one that can be given IV. Lispro and Aspart are called rapid insulins. They start working in about 10 to 15 minutes. They need to be given as the patient starts eating. You do not give them before the patient starts eating. One of the issues with regular insulin is you had to give it 30 minutes before the patient starts eating. And what happens to a lot of times, what do patients do? They don't wait, or they forget to eat. And either way, you end up with problems. NPH is a medium-acting insulin that lasts about 12 to 16 hours, and the peak is about 4 to 6 hours later. So the patient who takes NPH at 8 o'clock needs to be eating lunch about 12 to 1 o'clock. And then glargine is like a flat baseline that it doesn't have any peaks at all. It just has a flat base rate. Next, we have potassium chloride. It's a mineral. A lot of drugs can cause lowering of potassium levels. One we in fact learn is furosemide or Lasix. As a result of that, it can cause a number of problems, including sudden death and dysrhythmias. So a lot of patients are going to need a supplement of potassium chloride. So a couple things about it is we are using it to either treat or prevent hypokalemia. So you're going to need to monitor the patient's potassium levels. So some things to think about. As far as adverse effects go, abnormal ECGs, irregular pulse, muscle weakness, numbness, and tingling. Those are all associated with high levels of potassium. So if you're monitoring the patient's potassium levels, you will hopefully prevent those from happening. Reduce the risk that those occur. As far as interactions go, anything that interacts with the patient's potassium levels can potentially cause that. So diuretics, digoxin, and foods high in potassium ACE inhibitors. As far as nursing considerations go, you've got to have extreme caution when you give this to patients who have kidney disease. They have a lower tendency they get rid of potassium slower, so it's easier for them to overdose. So the rule is, no P, no K. Patient's not producing urine, you don't give them potassium. Second rule is no more than 10 milliequivalents per hour of potassium, especially when giving it IV. Next, we have levothyroxine. This is artificial thyroid hormone. There's multiple brand names. 2 of them I put down there for you, Synthroid and Levothyroid. As you're basically replacing the body's normal thyroid hormone, which is going to do all of these things: increase metabolic activity, increase gluconeogenesis, glycogenolysis, protein synthesis, cell growth, and brain CNS development. In the elderly, the most common reason you're going to give it is hypothyroidism. In kids, you use it to prevent a permanent condition called cretinism. As far as adverse effects go, overdose, called thyrotoxicosis, or a much cooler name, thyroid storm. And so it's basically too much of all of these things. So insomnia, tachycardia, angina pectoris, which is chest pain because the heart is beating too hard, sweating, weight loss, and heat intolerance. As far as the interactions go, it can interact with a number of things, including warfarin. Some pathomimetics would be drugs like phenylephrine or pseudoephedrine, decongestants, and then drugs that lower blood sugar. As far as nursing actions go, before you give it, you should take the patient's apical pulse, and you also need to educate your patient that this is a lifelong therapy. It's not something they're ever going to get off of.
Did you say that warfarin interacts with pretty much anything?
Yes.
So does this specifically
I was exaggerating when I said everything, but very specifically this, yes. One other thing is that it's got a relatively long half-life. So if a patient's miss a dose, they should just take their next scheduled dose. If they forget to take it in the morning and they take it in the afternoon, that's usually not as big a deal. But if they miss a day altogether, just keep taking it. Next, we have sertraline or Zoloft. This is called a selective serotonin reuptake inhibitor. And the way that it works is by increasing serotonin levels in neurons in your brain, in synapses in your brain. The main use of it is to treat depression and anxiety disorders. So obsessive compulsive disorder, social anxiety, generalized anxiety, social phobia, all kinds of that stuff. Those are all anxiety disorders. It can be used for all of those. As far as adverse effects, serotonin syndrome is possible in the first 72 hours, which is life-threatening. So to avoid that, you're going to start at a lower dose and then increase the dose after a week or 2. Weight gain and sexual side effects are the number 1 and number 2 adverse effects, and the main reason for patients going off these medications. By the way, teenagers like to think that they invented sex. However, old people are getting busy at a much higher rate than teenagers. The highest incidence of sexually transmitted infections in the country is among the elderly. So, don't be thinking that they're not going to be stopping their drugs just because, they're old. They don't do that anymore. They invented it, not you. Okay. So, sexual side effects and weight gain are the number one reason why patients go off it. It can cause an increase in impulsiveness, which can cause an increase in teen suicide risk, which is not necessarily a concern in the long-term care facility, but hey. Patients will often complain of vivid dreams when they're on these medications. And they can also complain about feeling flat. So they're like, well, I don't feel sad anymore, but I also don't feel happy either. And they can also have withdrawal syndrome, which is pretty nasty. So if a patient ever wants to go off it, they don't just stop taking it. They need to consult their physician and then taper off it slowly to avoid the withdrawal syndrome. If any of you are on an SSRI and you're like, hey, I'm gaining weight. I don't like that. I need to get off this medication. For the love of God, don't do it mid-semester and don't do it cold turkey. Capiche? Pinky swear? No, I'm going off mid-semester. All right. As far as nursing considerations go, interactions. Other psych drugs in general, one in particular called MAO inhibitors as a potentially life-threatening interaction. So you never give those at the same time. If you're going to switch a patient from an MAO to an SSRI, you got to have 2 weeks in the middle with no drug before you start the next one. As far as nursing considerations go, we're going to start them at a low dose, then increase. Educate about slow onset. It's going to take at least 2 weeks before it works, more like 6 weeks before it really starts working. And even then, it's going to build up in effect over a couple months' time. Educate them about adverse effects. Monitor teens to try and reduce the risk of suicide. And then a caution, if the patient has bipolar disorder instead of just depression, it can cycle them out into mania. As far as adverse effects go, we want to talk particularly about weight gain that is avoidable if the patient doesn't eat too much. These patients make them impulsive and also increase appetite. So if they can track their calories and limit their calories and then also exercise, you can actually completely eliminate the weight gain. But if you just leave people to the natural devices, they're going to gain weight. Next, we have donepezil, or Aricept. This is a cholinesterase inhibitor, so it increases the amount of acetylcholine present in the brain. In Alzheimer's disease, you have a destruction of acetylcholine neurons, which in turn causes it to be harder to make new memories. So what these drugs do is they enhance the amount of acetylcholine that's already there. They're still there. It's indicated for mild to moderate Alzheimer's disease. So basically, you're treating Alzheimer's disease, but it only works relatively early in the disease. As the patients get worse, it'll stop working. As far as adverse effects go, it is things that are basically enhancing the parasympathetic system. So nausea, vomiting, diarrhea, loss of appetite, weight loss, dizziness, drowsiness, weakness, blah, 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 blah. And then nursing considerations. Self-management. If you have a patient who's got Alzheimer's and is living by themselves, you have to have some sort of system so that they know when and how to take it. And then educate the patient's family. Okay, quetiapine or Seroquel. This is an atypical antipsychotic. Now, what is psychosis? It's a loss of touch with reality, and it usually takes the form of either hallucinations or delusions. Delusions are usually either paranoia, they're out to get me, or grandeur. Like, people think they're a secret agent or something like that. So, hallucinations or delusions. The adverse effects, man, there's a whole bunch of them. So, first we've got anticholinergic adverse effects. Dizziness, abdominal pain, nausea, vomiting, weight gain. So this weight gain is important, very similar to the SSRIs. That in turn can cause metabolic syndrome. Metabolic syndrome increases blood pressure, glucose, waist circumference, triglyceride levels, and reduces protective HDL, which in turn puts the patient at risk for heart attacks. So that in turn results in a black box warning for the elderly. It increases their risk of stroke and heart attack. And more importantly, it doesn't help in dementia. So a lot of times people go, oh, they've got hallucinations. No, they've got Alzheimer's dementia. And you can't treat Alzheimer's disease with antipsychotics. So although there may be patients who need antipsychotics, most of the elderly who are being prescribed them might be inappropriate. So this is one of those drugs that you want to avoid if at all possible. As far as nursing considerations go, assess psychosis. Are they actually in psychosis or not? Do they really need this drug? In the elderly, assess the need for continued use and manage adverse effects. Next, we have lorazepam or Ativan. This is a benzodiazepine. Benzodiazepines enhance the action of GABA in the brain, which is an inhibitory neurotransmitter. So it's going to cause patient to be drowsy, calm, maybe a little forgetful, causes anterograde amnesia. And so we're going to use this typically for anxiety, insomnia, seizures, and alcohol withdrawal to prevent delirium tremens. That's usually not happening in long-term care facilities, but if you're in a rehab facility, that might happen there. As far as adverse effects go, central nervous system depression, which can cause sedation, drowsiness, so cautions about driving cars. Anterograde amnesia. These drugs are sometimes used in date rape because of that. Roofies or Rufinol is a benzodiazepine that's used in horses. Respiratory depression by itself, these drugs are relatively safe. However, you've combined them with opioids or alcohol, the risk the patient may die of respiratory depression goes up dramatically. They're also addictive and they can cause paradoxical effects in some patients, especially elderly. They're on the Beers criteria list and you can see why. As far as interactions go, other central nervous system depressants, and especially alcohol and opioids. So, nursing considerations. Assess their risk, fall precautions, educate about the interactions, and monitor respirations if they're on other CNS depressants, and they're generally not appropriate for elderly. On that note, we are done.